Today's topic is on systemic lupus erythematosus, part 1. Now, lupus erythematosus is a systemic disease. It has its clinical presentations from optical to gastrointestinal, from cutaneous to pulmonary, even central nervous system. But its most common presentation are the cutaneous one and the musculoskeletal one. And it is the musculoskeletal presentation where it affects the joint, and it's the effect on joints where the patient suffers the most, and it is the most disabling of the problems, and it affects the quality of the life of the patients. That is the reason that SLE, despite being a systemic disorder, is taught as part of rheumatology, that is the study of the joints. So in this part 1 of the systemic lupus erythematosus, let's get on with it. So SLE, or systemic lupus erythematosus, is an autoimmune disease. Now, what is meant by autoimmunity? Autoimmunity is a condition where body's own defense mechanisms start to affect body's own cells and tissue, and this results first in damage, then in permanent loss of the function of the body or the tissue or cell in question. So in this systemic lupus erythematosus or SLE, what happens is that the cells and the tissue starts to get deposition of immune complexes, and these immune complexes comprising of both antibody, antigen, and the MHC complexes start to cling to surface of the cells and tissue, and they keep on persisting. And this persistence of the immune complexes is what gives the disabling of the functioning of the said tissue. Now, because of this disruption in the functioning of the tissue, which later on also starts to affect the structure of the cells and tissue, is what results in the pathogenesis of the SLE. Here is an example of what happens in SLE. This is an artery with its lumen cut out. This is the zoom in of that cutout. Now, here you can easily see that this hole is an immune complex, and it has particularly attached to the endothelium or the intima of the artery. Now, this immune complex comprises of the Y-shaped immunoglobulin, and the antigen, and the RBC. Now, because this immune complex is permanently attached to RBC, the functioning of the RBC is disrupted. So, because of the loss of its disruption of its function due to the autoimmunity, we see presentations of the hematological types. So this is how the autoimmunity works, and SLE, being an autoimmune disease, works by the deposition of immune complexes on the cells and tissue. Now, SLE is a very peculiar disease in a sense that 90% of its patients are of female gender. Now, regardless of that, the rest of the patients can be male. It can affect any ethnic group and any racial group. But the most interesting part is that the 90% of the SLE patients are of female gender. The male gender rarely gets any SLE symptoms. So let's start with the pathogenesis of SLE. Now, SLE is not a hereditary disease, but it has its roots, its pathogenesis in genetics. So it is a genetic disease, but it is not hereditary. So its genetic component is that there are certain genes which predisposes the body to the attack of the SLE, the autoimmunity of it. Now these genes give rise to or transcript and then translate certain proteins and certain uh, messengers which are essential for the functioning of body. Now when those genes are affected and the resulting proteins are not synthesized, such as these part of the complement system, the C1q, C2, C4, when they are disrupted, when the HLA or the human leukocyte antigen D2, D3, and D8 genes encoding for those are disrupted, then the FC recognition portion protein 2A, 2B, and 3A, those are disrupted, along with the release and deposition of interleukin 10, sometimes even 17 is also involved, along with MCP1. Now, MCP stands for monocyte chemotactic protein. Now, this is the protein that is responsible for the chemotaxis of monocytes and neutrophils towards the area of inflammation. Now, if this protein is not available along with the interleukin 10 and the other proteins that I mentioned, the process of the resolution of the inflammation will be halted. And because of this, the normal functioning of the tissue will be totally disrupted, and that will result in the loss of function. That is a crucial component of inflammation. So it can also result in other proteins such as PTP, that is the phosphotyrosine phosphatase N22. Now this protein is particularly important because it takes part in the signaling pathway for the T cells. So just like MCP1, which was important for the chemotaxis of monocytes and neutrophils, PTP is important for the signaling of the T lymphocytes, again for the resolution of the inflammation. And then if they are not present, inflammation persists. The other component of the pathogenesis of SLE, which predisposes the body to it, are the environmental factor. And these environmental factors are divided into two. One is the epigenetic changes. Now these epigenetic changes are the UV light, because we know that ultraviolet light has the tendency to mess up the genetic or the genetic material or the genome of the body. One common example is xanthoma. There are other examples too. So ultraviolet has the tendency to form dimers inside the genetic material. So whenever those dimers are formed inside the genes encoding for the proteins which are said here, this results in body's predisposition to SLE. Another example is the EBV, or the Epstein-Barr virus, and this is particularly important because this virus attacks children more frequently than adults, and attack of this virus usually results in the immunocompromised state, and because of this immunocompromised state, the body again becomes susceptible to the SLE. Another common but very frequent change that might give result to the pathogenesis of SLE is the infection. Some infection, especially in the immunocompromised state, can result in the start of the SLE in the body. The other change is the gender or the female predisposition. Like I said before, 90% of all patients with SLE are of female gender. Now, this is interesting because females, those who are either in the reproductive age, or those undergoing hormone replacement therapy, or those who are having oral contraceptive pills which contain estrogen, have the ability, or which are predisposed to SLE. Why? Because all of these contains estradiol, and estradiol has the tendency to give rise to certain proteins which then again predisposes the body to SLE. So because of the estradiol, females in the reproductive age, and especially those after the menopause undergoing the hormone replacement therapy, or because of a tumor, or those with estrogen containing contraceptive pills, are susceptible to the progression of an SLE. So these are the two main factors which predisposes the body to the SLE. Now, when the body is predisposed, when it is susceptible to the progression of the SLE, what happens is that there is an abnormal immune response. Like I said, SLE is an autoimmune disease. Now, in its autoimmunity and its response to the antigenicity, what happens is that that response is dulled. It is abnormal. Why? We will learn that further in the immunogenesis of SLE. But here it is suffice to say that all of this, the genes and the environmental factor, give rise to abnormal immune response. Now, this abnormal immune response can be seen here, like this is a dendritic cell, this is an antigen, this is a T cell, and this is a B cell. Now, you can easily see that this is the antibody, and this antibody is attached to this antigen. Now, dendritic cells are the one which give us innate immunity. Now, because of the abnormal immune response, its normal activity of binding antibody to antigen is disrupted, because the B cells either will not produce required immunoglobulins, or there's some problem with the signaling of the T cells, or there might be something else. Whatever it is, it will result in defective suppressive pathways. So what happens is that normal immune response becomes abnormal, and the suppression of the antigenicity, that the introduction of the antigen, is suppressed. So the suppression networks are defective. So this results in an auto antibody antigen immune complexes, and these are the complexes which then starts to accumulate, starts to deposit on the cells, on the tissue, and starts to disrupt their function and ultimately their structure. So as you can easily see here, that because of the formation of these immune complexes along with the disruption in the complement system, what is happening is that patient is undergoing inflammation. Now, this here, the patient is suffering from a cutaneous inflammation and inflammation in the kidney of the patient. Now, usually what happens is, in a normal response, the inflammation should have subsided over time. Now, because the response was abnormal and the suppressive network was defective, the inflammation persisted. And because the inflammation persisted, this resulted in certain clinical presentation and the disruption of the function and structure of the cells and tissue. Now, because of this chronic inflammation and because of this chronicity of the inflammation, this gives rise to chronic oxidation. What happens is that both the tissue and the organs are damaged. Now, if the damage is not detected earlier, it will become permanent. It will give to permanent disruption of the functioning of the organ. In this case, the functioning of the kidney. So you can easily see that the pathogenesis of SLE starts with the predisposition of the body towards it, because it's an autoimmune disease that body attacks itself. So there must be something wrong with the body for itself to do it. So what is wrong with the body is that the genes that encode for certain enzymes which are crucial for the inflammation, for the resolution of the inflammation, are not formed. So those genes are disrupted. Then there are the environmental factor, and these epigenetic and gendered predispositions starts to give rise to abnormal immune response, which then gives rise to abnormal immune complexes, which both deposits and persists, and this persistence then gives rise to prolonged inflammation. And this prolonged inflammation, in this case in kidney, along with chronic oxidation, gives permanent damage to the said organ. So this damage, if not detected earlier, like I said, will result in renal failure. It can result in atherosclerosis if the problem is in the artery. It can result in pulmonary fibrosis if the inflammation is instead of in the kidney, it's in the lungs. It can result in a stroke if its deposition starts to happen either the in the central nervous system, or it can even damage from the treatment. So a lot of scenarios can happen, but one thing is for sure, that an abnormal immune response and abnormal and persistent immune complexes will give rise to chronic inflammation, which then permanently damage the organs. Now we come to immunopathogenesis. For SLE, because it's an autoimmune disease, its histopathogenesis and its immunopathogenesis are equally important. Now, for the immunopathogenesis, what is important are the triggers. What triggers the body to give an autoimmune response? Now, we know that immunity is comprised of two components. One is the innate immunity, other is the adaptive immunity. Now, these triggers work in the activation of the both innate and the adaptive immunity. Now, what these triggers are, the first one is the defective apoptosis. Apoptosis is a process which is also called a programmed cell death. Whenever a cell reaches senescence or old age, it undergoes certain changes which are called deformation of plebs, and then it destroys itself. It's a normal process and it happens in each person. But in this instant, the apoptosis is defective. How it is defective is that there is not clearance of the apoptotic material. So whenever a cell destroys itself, that results in apoptotic debris, and that debris has to be cleared from the body. But if it is not cleared, all of the debris has the potential to become antigen, and those antigens have the potential to give rise to the autoimmunity inside the body. In this instance, because of the defective apoptosis, the nucleosomal material has become antigenic, and because of its antigenicity, the body is giving rise to autoimmunity, that it is starting to form auto antibodies. Now, because of this defective apoptosis, this starts in the activation of the innate immunity of the body. So the innate immune response is activated. The other problem, the other trigger that becomes part of the immunopathogenesis is the immune system dysregulation. Now, in the immune system dysregulation, what happens is that there is abnormal immune pathways, there is defective threshold for the immune response, and because of this, the T cells, B cells, and the cytokines starts to show defects. The T cells, both the CD8 and the CD4 version, start to give dysregulation. The B cells starts to form auto antibodies, and there is a sustained and defective release of cytokines along with chemokines. Now, because of this, because of the lower threshold for the immune response and the formation of the abnormal immune pathways, this activates the adaptive immune response. So, the other component of the immune system is also activated. So, this all results in the formation of type 1 interferons. Now, the formation of type 1 interferons in SLE is considered a genetic signature for the body, because the upregulation of genes which are responsible for the formation of type 1 interferons, when those genes are upregulated, this is considered a genetic signature for the SLE. So you can easily appreciate here that how the innate immune response is compromised. This is a normal cell with its normal antigens, and this is a macrophage with its antigens and Fc receptors. Fc is a portion of an immunoglobulin. It is a part of the Y structure of an antibody. So this receptor binds to the antibody or the Y structured immunoglobulin. This is a polymorphic neutrophil. So this antibody starts to clump with the antigen of a normal cell, and because of this clumping we get immune complexes. Now this can also come from nucleic acid sensors, and these also give rise to increase in type 1 interferons. So this is a normal, it can be a dendritic cell, it can be a macrophage, whatever it is, its surface antigen are starting to form abnormal complexes with the antigens forming immune complexes. Now for the other side. The other component of the immunity is the adaptive immune response. Now, in the adaptive immune response, this results in the formation of antibodies. So, antibodies are formed from the B cell. Now, B cell forms antibodies after the recognition of the antigen by the MHC protein. So, this is a dendritic cell which is releasing cytokines. It has the antigen. This is a T cell receptor. This is the MHC or the major histocompatibility complex, and this is giving rise to the giving rise to both the immune complexes, and the enhanced immune response is failed because this B cell is continuously producing these antibodies, but these antibodies start to get stuck in immune complexes in the adaptive immune response. So, this is the reason why the adaptive immune response is compromised, and it is triggered by the immune system dysregulation. So, all of this starts to result in autoantibody production, in the complement system activation, and then ultimately tissue damage. To summarize, the immunopathogenesis of the SLE has two triggers because there are two types of immunity, the innate and the adaptive one. Both are triggered, both are activated, and both start to give rise to the increased upregulation and formation of the interferons. And because of this, the formation of the immune complexes in both the innate and the adaptive immunity, we start to have autoantibody production and then the complement activation. All of this start to damage the cells and ultimately tissue, and then the organ function is compromised. Next, we have a skin biopsy. SLE is diagnosed via a variety of ways. The first one is through a physical exam. So, if the patient most commonly has a cutaneous presentation, it has a very typical one. So, if this typical presentation is present in the body of that patient, a skin biopsy is always taken. And a skin biopsy of an SLE patient has what is called an eosinophilic response. What happens is that there is deposition of antibodies between the dermal and epidermal junctions, and the deposition of antibodies between these junctions, these desmosomes, starts to give rise to the cutaneous presentation that is very specific to the SLE. Here in this skin biopsy, you can easily see that there is this deposition of antibodies along the interface and then along the vasculature, inside the cells. So this eosinophilic response is very characteristic of a cutaneous presentation in an SLE patient. Another common biopsy that is taken in SLE patient is a renal biopsy. In a renal biopsy, again, what we see is called an eosinophilic response, that there is an increased in the eosin staining of that particular biopsy. So in this renal biopsy, you can easily appreciate that there is the thickening of the lumen of the vessel. Its lumen, it's not normal, it is thickened. Why? Because of the deposition of the antibodies. There is also the infiltration of the lymphocytes. There are a lot of lymphocytes, these blue dots, inside the cells, and because of this, this is very typical of a renal biopsy of a patient with lupus nephritis. Now, lupus nephritis is a component of systemic lupus erythematosus. Now, some have cutaneous manifestations, some have pulmonary, but one of the most common one is a renal presentation, which is called a lupus nephritis. So whenever we suspect lupus nephritis, renal biopsy is taken. And this renal biopsy is very typical of a patient with lupus nephritis. Next, we have the classification of lupus nephritis. And this classification is according to the International Society of Nephrology and Renal Pathology Society. Now, this classification is very important because, like I said, the two most common presentation of SLE is one, the cutaneous one, and second, the renal one. So, lupus nephritis and its classification is necessary for every medical practitioner to learn. So, what is this classification? So, there are 6 classifications of it. The first one, or the class 1, is called a minimal mesangial lupus nephritis. In minimal lupus nephritis, what happens is that there is no mesangial change on the light microscope. There's only change on the immunofluorescence. So you cannot detect any change if you take a renal biopsy of the patient if you view it through an H&E or eosin hematoxylin stain and a light microscope. You can only view the class 1 through immunofluorescence. Immunofluorescence is a process where we start to see the deposition of antibodies inside the tissue by attaching it with a fluorescent material, and that fluorescent material and its fluorescence means giving off light. Its fluorescence gives us definitive proof that there is some deposition of antibodies inside this patient. Next, the class 2 is mesangial proliferative lupus nephritis. In mesangial 1, again, there is only hypercellularity of the mesangial tissue. It can not be seen on a light microscope, though you might see some thickening of the mesangial tissue, and it can only be viewed on the immunofluorescence. Next is the class 3 or the focal lupus nephritis. Now, focal lupus nephritis, either active or inactive, has both focal or segmental or global extracapillary glomerulonephritis, which is less than 50%, along with focal subendothelial deposition of antibodies. So this classification has 3 components that we will discuss further. In class 4, which is called diffuse lupus nephritis, again there's active or inactive focal, segmental or global deposition of extracapillary glomerulonephritis, which is more than 50%, and the deposition of the subendothelial antibodies is diffuse, it is not focal. So the difference between class 3 and class 4 is that in class 3 glomerulonephritis is less than 50%, in class 4 it is more than 50%. In class 3 the deposition, the subendothelial deposition of the antibodies is focal, while in class 4 it is diffuse, it is all over. Next is the class 5 or the membranous lupus nephritis. In membranous lupus nephritis, what happens is that there is deposition of antibodies only in the membranous area of that patient. So there might not be a mesangial change, there might not be a glomerulus change, but the membrane of the said glomerulus is deposited. So this is the class 5 or the membranous lupus nephritis. Class 6 is the advanced sclerotic lupus nephritis. In this nephritis, there is more than 90% of the glomeruli that are involved, and all of those glomeruli show sclerosing properties, that there is scarring and permanent damage to those glomeruli. Now, like I said earlier, that class 3, the focal lupus nephritis, has 3 classifications or sub-classification. In class 3A, there is active lesion and there is focal proliferative lupus nephritis. In the class 3, that is both active and chronic, we see focal proliferative nephritis along with sclerosing nephritis. So we see both the active and the chronic component of the focal lupus nephritis. In the class 3 of the focal lupus nephritis, which is called the chronic inactive lesions with glomerular scars, is what we see is that we do not see any focal proliferative nephritis. We only see sclerosing nephritis, that there is permanent focal scars in the glomeruli of the kidney. Now, the class 4, that is the diffuse lupus nephritis, has again 6 classes, and these 6 classes can be clumped into 3 pairs. Now, the first 2 pairs are, one is, these are the ones with the active lesions, but in this one there is diffuse segmental proliferative lupus nephritis, and in this one there is diffuse global proliferative lupus nephritis, and both of these are active lesions. So the difference in these both classes, despite being diffuse, is one is segmental, other is global. Now, segmental is different from focus. Focal is by the difference in length. Focal is a single point of scar or inflammation or damage. A segment is an enlarged length, but not the whole length. That would be the global. Next pair is the one with the active and chronic lesions. Again, these can be divided into diffuse segmental lupus nephritis along with sclerosing nephritis, and then again with diffuse global lupus nephritis along with sclerosing nephritis. So again, the difference here is the introduction of the chronic lesions, the sclerosing nephritis. And again, there's a difference between the segmental and the global proliferation. The next pair is the chronic inactivation. In this one, there is chronic segmental lesion, chronic scarring. There are no active lesions. There is segmental sclerosing nephritis. And in this class 4G with chronic, we have the chronic inactive lesion with scar, but this is global. So in this pair, there are no active lesions, only the chronic lesions which have turned into scars. And these scars can be in this class segmental or in this class global. And this class is the one where there is global sclerosing, and global sclerosing nephritis is the one which ultimately results in end stage renal failure. Next, we'll start with the clinical features of SLE. So, one of the most common clinical presentation of SLE is the musculoskeletal manifestations. Now, here is a person with its musculoskeletal anatomy. The first symptom that is manifested in a patient with such presentations is polyarthritis, which can be both mild to disabling, and this results in the inflammation of hands, fingers, wrists, knees. These are the usual areas where the polyarthritis attacks. Now, this can also result in joint disformities, but it only happens in about 10% of the patient. We also see rheumatoid arthritis in such patients. So it is also possible to have both the rheumatoid arthritis and SLE in the same patient. So in these patients, they have rheumatoid arthritis in their knees along with SLE presentations. Now, because of the rheumatoid arthritis, the patient has increased level of pain as opposed to having only polyarthritis. Now, one complication among the musculoskeletal manifestation is the ischemic necrosis of the bone. When patient suffers from musculoskeletal manifestation, but the pain inside the bone is unilateral, because in polyarthritis it is usually bilateral because the both joints are affected. But if it is unilateral, ischemic necrosis of bone should be considered. It should be investigated further and should be ruled out, because ischemic necrosis can result in amputation of the said patient. Next clinical manifestation or feature that we're going to discuss are the cutaneous one, which are again one of the most common ones. Now, a cutaneous manifestation first starts to have manifestations as lupus dermatitis, and this is a very typical presentation of how lupus dermatitis presents itself. Now, lupus dermatitis has three subtypes. It's either acute, it's chronic, or subacute. But whatever the subclassification is, lupus dermatitis has to be treated, and usually it is treated with topical glucocorticoids. Sometimes even retinoic acid is used, and even if it persists even after that, immunosuppressants are considered. Another cutaneous manifestation of an SLE is a discoid lupus erythematosus. In DLE, we see these clearly demarcated lesions which have central atrophy along with elevation and necrosis of tissue. Now, this discoid lupus is very common and usually results in disfigurement of patients. So, if it is detected earlier, the treatment of the patient must be started as early as possible with much given thought to the treatment. Another manifestation is that they suffer from photosensitivity. They also suffer from erythema, and this erythema is the one that has also some slightly raised uh, characteristic to it. It's not just the redness of the skin, it has a central raised point. Now, butterfly rash or malar rash is pathognomic of SLE. So, if you see a patient with a butterfly rash, butterfly in the sense that the patient has rash over both the cheeks and in a fashion that covers both the petrous bone and the cheeks and gives the appearance of the two wings of the butterfly. This presentation is very pathognomic of SLE. And if you see a person with such presentation, workup on SLE must be started. Another presentation are scaly red patches, and these scaly red patches are clearly demarcated. They have scales, and they are not found in isolation. They are found along with either the discoid or with lupus dermatitis. Then we have the urticaria and lichen planus like dermatitis. Both of these, along with scaly patches, are only present in either lupus dermatitis or in discoid lupus. So they come not in isolation but as a part of the manifestation of the SLE. Now, sometimes in clinical presentation of SLE, we also see some bully, that is the boils that are formed on the skin, and sometimes we also see paniculitis. Paniculitis is a term where we define that that the adipose tissue that is usually present underneath the skin has undergone inflammatory changes. So whenever there is inflammatory changes in the subdermal adipose tissue, it is termed as panniculitis. So this rounds up all the cutaneous manifestations of a patient with an SLE, with particular emphasis on lupus dermatitis and discoid lupus, and the butterfly rash or the malar rash being the pathognomic feature of an SLE. Pathognomic means that it is only it only appears in that particular disease. So malar rash or butterfly rash only appears in patients with SLE. Another manifestation that we discussed earlier is the renal manifestation. And renal manifestation usually results in nephritis, that is the inflammation of the whole tissue of the patient. This results in not only lupus nephritis but might also give rise to nephrotic syndrome. Now, nephrotic syndrome is a term where There's a triad of increased albuminemia, hypertension, and dyslipidemia. So, because of this nephritis and because kidneys play a huge role in the regulation of the hypertension, in renal manifestation, hypertension is very commonly seen. Next, we'll discuss about the nervous system manifestations of the SLE. The first one is a headache, along with psychosis, cognitive dysfunctions, myelopathy, and even seizures. But the problem is that these nervous system manifestations are very common, that they can be part of another disease. So, workup must be done to differentiate them, that either they are because of some other disease, some other pathological process, or they're a part of the nervous system manifestation of the SLE. And when it is confirmed that they are due to SLE, it must be confirmed either they're due to the presence or the deposition of the immunoglobulins inside the nervous system, or due to the vascular changes that occur in SLE. So the difference must be made because our treatment of the patient changes accordingly. Next clinical feature that we're going to discuss are the vascular occlusions. Now, vascular occlusions are either, the most common one is the atherosclerosis, where atherosclerotic plaque starts to narrow the artery that results in its stenosis and then ultimately the ischemia. Another way vascular occlusion can happen is by spasm. Now, because the arteries have a middle layer composed of muscles, they are prone to spasms, and these spasms result in the narrowing of said artery, and because of this narrowing, this results in occlusion. Another one is a coronary dissection. Dissection, an arterial dissection means the introduction of blood between the layers of the artery. This usually happens in larger arteries where there is some type of either pathology or some structure alteration is already present, which results in introduction of blood between the layers of the artery. But whatever the case, due to dissection, the flow of the blood is compromised, and this results in occlusion. Another way occlusions can occur is by having a difference in the demand and the supply of the oxygen. Now, the demand and supply can be due to a number of reasons. Lungs can be compromised, the arterial system that delivers the blood, that can be compromised. There are a lot of ways, but a simple imbalance between the supply and the demand, like in exercise, can also occur in occlusions. So this gives a perfect example of a patient with normal flow and one with the abnormal flow. Now, in this patient, there is atherosclerotic plaque along the intima of the patient, and because of this, less blood is flowing as compared to this one. Now, because in SLE patient, transient ischemic attacks along with strokes are very common. So consideration must be given to vascular occlusions in SLE patients in order to avoid those. Or if the patient do suffers from strokes or is transient ischemic attacks, workup must be done. Another way vascular occlusions can present in SLE is by myocardial infarction, that is the coronary supply that is compromised, or it can be due to accelerated atherosclerosis. Like I said, SLE is an autoimmune disease, and because in autoimmune disease there is deposition of antibodies, and these antibodies can speed up the process of atherosclerosis, because atherosclerosis is a process which happens over time through the deposition of plaque over the endothelium of the artery, but that can be accelerated by the deposition of autoantibodies in SLE. So this can happen and must be taken into consideration. Our next clinical feature that is present in SLE are the pulmonary manifestations. So in a patient with an SLE, pulmonary manifestations are not uncommon, though they are rarely seen. So the first and the most common complication that can happen to the lungs of an SLE patient is pleuritis, that is the inflammation of the whole parenchyma of the lungs, and this is usually accompanied by pleural effusion, but this pleuritis can happen with or without pleural effusion. Now, because of its autoimmunity, during SLE, there is infiltration and proliferation of immunoglobulins in the interstitium of the lungs, and that interstitium then starts to get fibrosed, and because of this fibrosis, lungs start to shrink in size, and this is what is called a shrinking lung syndrome. And a shrinking lung syndrome is usually due to widespread fibrosis inside lungs, and in an advanced pulmonary manifestation of an SLE patient, a shrinking lung syndrome is very characteristic. Another thing that we see along with the shrinking lung syndrome is the interstitial inflammation. Now, for shrinking lung syndrome to happen, interstitial inflammation before that occurs, and that happens due to the deposition and the presence of immunoglobulins in the interstitial tissue of the lungs, and that results in inflammation and the reduced function capability of the lungs. And sometimes, if it is not resolved and the interstitial inflammation does not get fibrosed, this can occur into intraalveolar hemorrhage, that blood starts to pour out inside the alveoli. Now, because we know that SLE, due to its autoimmunity, is a hypercoagulable state, bleeding is a very common presentation that can happen in a patient with advanced pulmonary manifestation. SLE patients can also manifest with cardiac issues. And for cardiac issues, one of the two most common problems that are found are the pericarditis and myocarditis. Pericarditis is the inflammation of the tissue that surrounds the heart, and myocarditis is the inflammation of the tissue of the heart. Both are first seen in the patient with cardiac manifestations in an SLE patient. But we can also see sometimes fibrinous endocarditis of Libman sacs. Now, this endocarditis is of particular interest because it is also called non-bacterial endocarditis, because we know that endocarditis usually occurs due to some kind of bacterial infestation. Now, because this one is due to deposition of autoantibodies. This one is called the Libman-Sachs endocarditis. Another problems that SLE patients might face are valvular insufficiencies. Now, valves are fibrous tissues. They are formed like thin leaves and they must be preserved with accurate structure. So, any deposition upon them will result in their decreased functioning. Now, if there is deposition of antibodies on the valves, this will result in reduced functioning of the valves and the ejection fraction, the circulation of the blood throughout the uh, lungs, and the functioning of both the atria and the ventricles will be compromised. So, valvular deficiencies should also be checked in an SLE patient manifesting cardiac issues. Another manifestations are the hematological manifestations. Now, they can result in anemia. Now, this anemia is of normochromic normocytic type. So, this indicates that this anemia is of chronic nature. This can also manifest as hemolysis. Like I said, that sometimes immune complexes can bind to RBCs, and when they bind to RBCs, due to the chronic nature of SLE, hemolysis can occur, and an unchecked hemolysis can result in prehepatic jaundice. So, this must be taken into consideration. Another manifestation is leukopenia, that is the reduced white blood cell count, usually less than 4,000 per microliter. Another is the lymphopenia, that is less than 1,000 per microliter. Now, lymphopenia is a part of leukopenia because white blood cells are composed of 5 types and lymphocytes are one of its types. And lymphocytes are usually found in a percentage of around 35 to 40%. But in patients with SLE, this percentage is dropped. So instead of having 40%, they are usually found in less than 10% of overall total leukocyte count. Now, in the blood of SLE patients, platelet count can also get reduced. It can be less than 100,000 per microliter. But if the patient's platelet count is more than 40,000 per microliter and there is no evidence of any bleeding, no treatment or any action is taken, because then it is considered normal. Only if it drops less than 10,000 per microliter or there is some evidence of bleeding inside the patient. Next manifestations in a SLE patient are the gastrointestinal ones. Now, for the gastrointestinal ones, nausea and vomiting, along with diarrhea and diffuse abdominal pain, that the patient is unable to pinpoint the origin of where the pain is coming from. It's not migrating, it is not moving. So, this diffuse abdominal pain, along with sometimes sepsis, is very common in patients with SLI because of the autoimmune peritonitis. Now, whenever autoimmune peritonitis happens, these presentations are most commonly seen. So, a patient with diagnosed SLE presenting with these symptoms must be considered for autoimmune peritonitis. But autoimmune peritonitis is not the only condition that can happen in a patient manifesting gastrointestinal symptoms in an SLE. Vasculitis can also happen. because we know that the peritoneal cavity or the abdominal cavity is filled with not only intestines but also vasculature. And if vasculitis is to happen, this results in ischemia because there is reduced blood flow to the viscera. And because of this ischemia, sometimes necrosis can occur, and that necrosis then results in perforation of the bowels. And this is one of the worst outcomes that can happen to an SLE patient with a gastrointestinal manifestation, because perforations are not only increase the morbidity of the patient, they increase the overall mortality. Now, vasculitis, if it is not uh, giving ischemia, can also result in the bursting of the said vessel, and this results in bleeding. And bleeding inside the abdominal cavity is of particular interest because it is not usually seen. It cannot be usually detected on a physical exam. It is usually detected on particular imaging like CT scan or an MRI. Now, because the diagnosis of SLE is usually physical and of chemical or laboratory in nature, this can be sometimes be missed. So if a patient, an SLE patient, is manifesting gastrointestinal symptoms, bleeding should be considered and must be worked up and must be ruled out. Another manifestation with an SLE patient are the ocular ones. Now, the ocular ones are the one that happen inside the eye of the patient. The most common manifestation in an SLE patient is the Sika syndrome, also called the Sjogren syndrome. This is also an autoimmune syndrome in itself, and this results in dry eyes. Now, it can result in other symptoms too, but for the eye, this results in its dryness. So, it's called the Sika syndrome or the Sjogren syndrome. The second most common manifestation is a non-specific conjunctivitis. Conjunctiva is the membrane which covers the eyes and protects the sclera. Now, if there is an inflammation due to the deposition of the autoantibodies, this can occur in the inflammation of that conjunctiva, and it is very commonly seen in patients with SLE. But this is not the only condition that is seen in patients. Sometimes optical neuritis or retinal vasculitis can happen, and both of these are very serious condition, because in optic neuritis, the optic nerve if compromised, and in retinal vasculitis, the vasculature of the retina is compromised. Both of these lead to the blindness in the patient. So, if the patient is manifesting ocular characteristics, Sika syndrome and non-specific conjunctivitis are the first one that we observe, but they should be worked up further, and fundoscopy must be done in order to rule out any signs or symptoms of retinal vasculitis, optic neuritis, because they lead to permanent blindness. So, in this lecture, which is the part 1 of the systemic lupus erythematosus, first we learned what SLE is. Then we learned about that how it happens, what is its pathogenesis. Then we learned that its pathogenesis is equally important along with its histopathogenesis. Then we learned about its different presentations from the common renal and cutaneous manifestation to the uncommon ocular, gastrointestinal, and hematological manifestations. We learned about all of those in this lecture. So, thank you so much for watching sqadia.com.